I think the first thing is that we don't really have a definition for what referred pain is that everybody agrees on. So I think that that's kind of a problem. Yes, when we do our DCTMD, for example, we ask, is the pain staying under my finger or is it kind of going somewhere else? And we kind of say that if it's within the boundary of the muscle, it's spreading, but if it goes outside, it's referred. But we can also say that in studies in other parts of the body where they, for example, they press the gastrocnemius, for example, and pain goes down to the knee, is that actually referred pain? Is it pain spreading? So we really don't have, I would say, a consensus definition. On the other hand, I think we kind of all agree for the most part what happens in the central nervous system. So I think most people agree that what's responsible or may be responsible for referred pain is that there is convergence of the neurons, the nociceptors, and that then if the stimulus is intense enough or painful stimulus, there's a masking of synapses in the central nervous system, and then this kind of leads to new pain areas being discovered, for example, and then this can lead to referred pain. I think in general, whether we're right or wrong, most people agree with that. I think the problem is mostly in the periphery. So I think in that regard, then we have people who think that trigger points are responsible for referred pain. So there's very specific area of the muscle that's in a taut band and that is responsible for referred pain. And then I would find myself more on the other side, which is that I haven't really seen a lot of evidence that these trigger points specifically exist. And as such, I think it's just a part of the muscle that maybe is a little bit more sore. And also, of course, if you press more, it's more sore. And then you may get referred pain from that. But I don't necessarily think that you need to have trigger points to do that, to cause referred pain. I think it has more to do with how intense the stimulus is when you press on that muscle, or the pain in the area when it's not regarding palpation, when it's just if the patient is chewing or if it's just painful, how intense the pain is in the area. Yeah.
I think that's really interesting that you went into the whole theory of trigger points with that. And I'd like to hear some more about what some of the implications of the data you've collected are. Before we go there, maybe let me jump to a study that I thought was very interesting that you were the lead author on, published in 2018 in Pain, the journal Pain. The study is titled "Comparison of Masseter Muscle Referred Sensations After Mechanical and Glutamate Stimulation," a randomized, double-blind, controlled crossover study. So I think we want to go into this study with you a little bit. Let me ask you real quick before we ask you some specifics about this, though. What do you think that we clinicians and researchers maybe get wrong frequently in our understanding of pain referral?
Yeah, I don't think necessarily it's something that we get wrong, because I don't think we know exactly what's right. But at least I can tell you what is the resistance that I get when I talk to other people who don't share the same opinion as I do, at least. And the first thing is that, and we've had physical therapists, for example, who come to our to do research with us, and they're always very surprised when we do our experimental models and we show them that you can elicit referred pain without looking for a trigger point or so. So there's always some resistance to kind of that concept that you can just go there, press on any part of the muscle, and with 2 kilos, so you kind of cause some pain in there, and there's a high likelihood that you'll get some pain referral. So that's the first thing, is that I think that we need to understand that perhaps, at least our studies show that the more pain you cause, the more the chances of you getting referred pain increase. And if you think about the way that we kind of look for pain referral sometimes and trigger points, which is kind of by macerating the muscle and actually causing a lot of pain, then you can see that that is a problem, because then there's a higher likelihood that you're going to get a referral if you continue to badger that muscle until you get something. So that's the first thing that I think we need to be aware of. And then the second thing is kind of the way in which pain referral can go. So I think, for example, just as the other day in the clinic, I had a patient with chronic tension type headache. And when I was doing my examination, got to the trapezius, and the pain was kind of referring, and they said it was reproducing their headache. So at this point, I think, and even the patient thought that, so the pain is coming from my trapezius. And I think there are plenty of studies that kind of say this, that if you get this pattern of referral to the head, then it's most likely coming from the trapezius. But we've also shown that, and there are other studies by the group in Aalborg, by Grav and Nielsen, that show that if you have an area that has pain at the moment, or if you have an area that has had pain, so in the case of these Aalborg studies, it was patients that had twisted their ankle a while back. So what happens is that the pain tends to refer to that area much more than if you had not had that painful experience. So going back to the tension type headache thing, you can think that if you do have tension type headache and you press on the trap, the chances of it referring to your head increase because you already have that chronic pain experience, most likely because there's some kind of rewiring in the central nervous system that facilitates it so that the referred pain goes there instead of maybe your jaw or a tooth or your nose or whatever it is. So I think these things we also need to be aware of, that it's not just if I press here and pain goes there, then the pain or the headaches that we're having in this case are because of the trap. No, it could be that the pain is only going there because you already have chronic headaches, for example.
That is very interesting. So let me ask you along those lines, what do you think then is the therapeutic benefit of doing trigger point injections? Do you think it has any therapeutic value to go to that trap and try to anesthetize it in order to help with that headache? Or are we, what's the benefit of adding that type of therapy in our practice?
Yeah, I think it depends a little bit on, of course, on the specific patient, but I think therapeutic injections have value in terms of, number one, cutting kind of the pain cycle in a way. So you're shutting down, even for a short period of time, you're shutting off some pain. And I think in some patients that has some value. On the other hand, if we're talking about trigger point injections and the needling, I don't have a research that explains why these things work for some patients, but I could guess that in a way when you do, or when we do that kind of needling, especially dry needling, that you're activating the patient's endogenous pain system. So it could be in that way, perhaps, that it does work in a way. And that's kind of a little bit, in my opinion, consistent with the fact that patients, maybe things work for a week or two, and then maybe kind of the pain goes back a little bit when we do that. So it's not like, at least my experience is not that it is a definite treatment. And I think we sometimes all get stuck with that patient that wants to come back and back and back to do those therapeutic injections. And I think the fact that you're basically just giving a burst to the endogenous pain system for a period goes more with that, rather than you're breaking up, for example, a trigger point. But again, that's only my opinion.
Mm-hmm.
Well, I'll tell you, Fernando, this whole idea that you've described of, maybe maybe this is pain following in the tracks of previous pain, right? It's not necessarily the case that you have a tension type headache source in a trapezius. I think this paper of yours is the first time I encountered that idea, and I think it's absolutely fascinating. I hope we can see some more research exploring this further. The idea you just mentioned about, maybe activating endogenous opioid systems, obviously we're getting a little bit speculative here, but wouldn't that suggest that you could needle somebody almost anywhere and get a benefit from this? Almost more of an acupuncture model as opposed to what we think of as a trigger point injection.
I would say basically that the more painful, or if a place is more painful or causes more pain when you needle it, the better, if this is what we're talking about. And there is at least one study that I can remember, which I think maybe came out 2 years ago, which is by David Yanitsky. and I think it came out in Neurology, if I'm not mistaken. And basically what they did was they used TENS, which is also known for activating the endogenous pain system. And basically what they did was they put TENS in the forearm, and they were able to reduce the number of migraine episodes that a patient had during a month. So I think if you consider this, I remember that I was at the headache course when this paper came out, and the neurologists there were all a little bit suspicious of this because migraine is not supposed to work like that in a way. It's a different breed of headache in a way. But the fact of the matter is that it was a pretty well done, randomized, blind controlled study. And that is exactly what happened is he did TENS in the forearm, and it decreased the number of headache episodes. So I think there is some value to saying what you just said, that it doesn't really matter where you do the injection, or in this case, the TENS. What matters is that you're able to activate the endogenous pain system in a meaningful way, and you probably get some results.
So going back again to your study, the one published in Pain in 2018, what questions motivated that study in order to compare pain referral stimulated by glutamate versus mechanically stimulated? And if you don't mind giving us a little brief, summary of your results in that study.
Yeah. So basically the two ideas were, one was that we already had a study or two studies where we showed that referred pain seemed to be kind of across the board consistent with the more pain you cause during the palpation, the more referred chances of eliciting referred pain you get. So for example, we used 2 kilos and you had much more referred pain with 2 kilos than with 1.5 kilos, which for the most part are below the pain threshold, or 1 kilo maybe around the pain threshold. So one of the ideas was that we wanted to check if we could do the same with another modality, in this case, the chemical modality, which was glutamate, which is a substance that's been shown to cause pain. And we also wanted to see if it was just the pain, or if it was actually the force that's being applied, because when you palpate the muscle, you have both a mechanical deformation of the muscle with the force, and you also have the pain, the nociception that's caused. So we wanted to find a way to remove the force from the equation, and that's why we chose the glutamate, because we're not palpating anything. And then the other thing that we also wanted to see with this was that if in 2 different sessions we would see any changes in where the pain was referring to, which goes a little bit back to kind of that preferred referred pain location that we were talking about before. And basically the results were similar to what we've had before, which is that regardless of its mechanical or glutamate or chemically induced referred pain, it doesn't really matter. There was no difference. What matters is that the more painful the stimulus, in this case in the masseter muscle, the higher the chances of eliciting referred pain. And then at the same time was that between sessions, the pain kind of referred very, very closely in both sessions. Sessions were like a week apart. So I think, again, that kind of shows that in different individuals, pain varies, or referred pain varies. So some of them was in the mouth, others was in the temple, others was behind the eye, and so on. But within the individuals, it was consistent to the same place.
So here's something that surprised me about that study, is that the intensity of the referred sensation was really not strongly correlated with the intensity of the sensation at the site where the stimulus was administered, in the masseter, if I understood the findings correctly. Yep. That really took me by surprise. Were you surprised by that? And what do you think is going on with that? It just seems like intuitively, if you have a stronger local stimulus, well, you're going to feel stronger referred sensations. But yep, it wasn't the case. What do you think about that?
I was also not expecting it, especially because there's, again, another study from Albert where they had looked at something similar to that, and they actually did find a kind of a correlation between those two. We thought about it a little bit, and of course, again, it's speculation, because and that's actually one of the things that we are working on at the moment, is trying to address these questions. We have a few studies running about if we can modulate the way in which the location of referred pain, and we also have some studies seeing if we can explain exactly why we didn't find a correlation. And the answer that we came up with is that maybe it depends a little bit, again, just on the central nervous system, on the endogenous pain modulation. So maybe there were some individuals that when we pressed, it was enough to cause referred pain, but they activated that endogenous pain system, and maybe things kind of weren't as intense. But it could also be perception in a way. Maybe some were a little bit more concentrated on what we were doing in the masseter, and maybe they weren't paying so much attention to the intensity of the pain or sensation in the other area. So we don't know, but these are the two things that we kind of, I think, wrote in the paper that could explain that in a way.